welcome. This is Here's to Your Good Health. I'm Linda Prezioso, a nurse practitioner at Family Medical Center in Rocky Mount. I have with me today Dr. Sridhar.
Akshay Sridhar, that's right. Yeah.
Sridhar.
Yeah, you got it. That's pretty good.
You know me, people. I get names wrong. Anyway, he's a urologist for UNC Health Nash. I did it.
You got it.
I did it.
Never a doubt.
And he's going to talk to us about men's health primarily. Women obviously have some problems that need to see a urologist as well. But isn't this Men's Health Month or something?
Well, November is going to be ending now, but yes.
Yeah,
that's
we're
right. Yeah.
getting it at the tail end.
That's right.
So we'll be talking about men's health, but urology in general as a specialty, what it does, who you treat, when you need to see Dr. Sridhar or somebody else over in that office. So welcome. So nice to have you with me.
Thank you very much for having me. Appreciate it.
Yes, and I said, you're new, right? Well, he's been here 2 years. So
2 years now. That's right. A little over 2 years. Yeah.
Time flies when you're having fun.
Really, I'm a Southerner now.
Are you?
I'm a Southerner now, officially.
Yeah, me too. Prezioso is just not a
Southern name.
Not like yours. We're one of those, but they call damn Yankees. We come here and we don't.
That's right.
We don't go back.
Yeah.
So tell me a little bit about yourself. You've been here 2 years. Where did you move from?
Yes, I moved from New Jersey. That's
Okay.
where I mostly grew up. Went to school there, trained there, did my residency, and then I moved down here for the job. Yeah.
Okay.
In central New Jersey, in a town called Plainsboro. That's where I mostly grew up, near Princeton.
Okay. Well, my husband's from Hamilton.
Oh, okay. Very close.
Yes.
Yeah.
Right around, just probably in the opposite direction. I'm not exactly sure, but
Yeah,
I
but
know
it's
that
very close.
Hamilton isn't far from Princeton either.
Not at all.
So with a name like Prezioso, you've probably heard that name before.
I have, yeah. Well, there's a lot of Italians in.
Yeah. Oh yeah, lots
New Jersey,
of Italians
right?
in New Jersey. Yeah. And there's lots of Preziosos, and I don't even know if Bob's related to them all or not. There's just.
Of course he is.
Of course he is. They're all
big
probably.
families.
That's
right?
it. That's
big
exactly
families.
it.
Yeah.
Big Italian families. So what school did you go to?
So for undergrad, I went to Rutgers University.
Sure. Of course.
I did biomedical engineering actually. That was my major. I graduated degree with that, and then I did my master's also in biomedical engineering.
Okay.
So the original plan, of course, was to go to medical school, but I had to have a backup plan. So I did engineering instead. So just in case medicine didn't work out, I can go into consulting or whatever you can do with an engineering degree.
So apparently medicine worked out.
It worked out, thank God.
Yeah,
That's right.
So did you do all of your, where did you go to medical school?
So medical school, I went to, it's multiple names, it's been changed, but it used to be the University of Medicine and Dentistry of New Jersey in South Jersey, in Stratford, New Jersey. But now I believe it's called Virtua School of Osteopathic Medicine.
Oh, are you a DO?
I am a DO.
Okay.
That's correct, yep.
Okay, yeah, I like DOs. We've got several that work at our office.
Nice, thank you.
Yeah. So did you always think you wanted to be a doctor?
Not always. No, my first love was astronomy. Still is. If NASA came to me and said, we want you on the next shuttle, I will happily go. However, my wife may object.
Yeah.
She may have some different plans, but
yeah.
I would love to go, yeah.
Okay.
That's still, I
Okay.
love astronomy.
Okay, so, but you can't, there's probably not a whole lot of job opportunities in astronomy.
That's right, yeah, it's difficult.
It's pretty limited. I don't know if you know Dr. Rich Michael, he's here.
Yeah.
He's an astronomist. He's a big astronomy guy. He's got a big telescope and the whole thing.
He always invites people, I believe, right?
Yes,
to always look
yes,
over.
you're going to have to hook up with him.
I will definitely
He puts
have to.
the telescope in the back of his pickup truck, and then he's always looking for, when there's a comet that's going to be shown or something, he goes and sees all that.
That's amazing, yeah.
It's pretty interesting, yeah.
Yeah, so I did that, but, my uncle said, hey, that's a difficult field to go into, only for job opportunities wise. So he said, think about medicine, and I was always into sciences, and so I learned about medicine, and I said, this sounds like a great field as well, and so I just kind of put my eggs in that basket and just went with it.
Apparently it's worked out for you.
It has, thankfully.
Yes, that's good. So what made you go to urology?
Yeah, that's a great question as well. So in medical school, I initially entered thinking I was going to be a cardiologist. And it's a great field. Cardiology is a fantastic field. However, as I started my rotations, which we typically do our third year, I really, coming from an engineering background, enjoy working with my hands. And in cardiology, it's more of a medical subspecialty, unless, of course, you go into interventional or cardiac thoracic surgery. I did my general surgery rotation, and I really enjoyed it. And so I enjoy abdominal surgery. But I looked at the general surgery schedule. I looked at the lifestyle, and I said, "This is a tough, it's a tough lifestyle."
Yeah, especially if you're in a tertiary care center,
Exactly.
you're on call and
all the time.
trauma. And,
Yeah, and my friend from college was actually in the urology residency at my home institution, and he said, "Why don't you check out urology?" So I did it for a day. And it's nice because it's a great mix of surgery and medicine. So it combines kind of the best of both worlds. And the lifestyle is a little bit better.
Yeah.
And so
a little bit more 9 to 5.
Exactly. And so I said, okay, I just made up my mind, and that's what I did.
Awesome. Now, do you guys have to take call, or does...
Yeah, we take call. Yeah, so now that we have 4 partners, we take, it's every 4th day.
Okay. That's not too bad. But
No, not bad at all.
Do you have to go to the hospital if they call, or do the hospitalists do that?
Generally, well, as far as admissions go, if someone comes in through the emergency room, the hospitals are fantastic and they take care of it. We admit to their service, and then we are usually the consultants. Yeah, so I don't have to go to the hospital to admit the patient. However, if something is emergent that comes through the ER, we do go to the hospital. Yeah.
I worked in the ER 100 years ago when before hospitalists. They just started hospitalists probably the last 5 years of me being in the ER.
Yeah.
And so, I knew all the docs because everybody was on call.
Right.
And I was always there
at all
when
times, right?
somebody was there that had to get called. And we had one fella, he had sickle cell.
Okay.
And after he had sex, sometimes his erection wouldn't go down.
Yeah, a little
And
priapism.
Yes, and so then he'd have to come, and I watched many needles being stuck in the base of that penis, and it's
poor
I
guy.
know
Yeah.
I know it was terrible.
But hydration,
Yeah.
oxygen,
Yeah.
and then of course you have to drain
Yeah.
it.
Yeah.
If none of those other things
Yeah,
work.
and I just remember him because it was just painful to me to have to watch and have to help with.
It's painful for most
Do
people to watch.
And so you still see some of that, I'm sure.
We do, not as frequent. I should knock on wood, pun intended, I guess, because I just, it's not frequent, which is great, because usually these things happen at 2 a.m.
That's exactly right. That's
happens
exactly
at 2 a.m.,
right.
so
Yes,
it's never a convenient time, but it's okay. I mean, it's not as frequent, which is good.
Okay, that's awesome. So is there one particular portion of urology that you like over others? I mean, you like surgery, or?
I do. I think we all 4 of us, the group consists of actually 4 people now. So it's myself, it's Matthew Pazak, he's been there the longest. It's AC Afiadata. He came, I believe, a year before I did. And now we have a new person as well. His name is Andrew Cowder. He came from New York. And so the 4 of us, we all went into this for a reason, and it's because we like surgery. Yeah. So we definitely like operating. I specifically like operating as well. But my interest lies in benign diseases of the prostate. So, benign prostatic hyperplasia, enlarged prostate, all of those things encompassed. I love. That's one of my main niches. But of course, I deal with other general neurological issues as well.
Sure.
Yeah.
You got to take what comes in the door.
Yeah, exactly. Whatever comes in, we'll take care of it.
That's right. That's exactly right. And I don't know if any of you have ever had opportunity to go to his office. I guess it's not an opportunity to go to the doctor, but they have a great office. They have a great staff. You can always get in there. I've never had a problem getting a patient in there. They're available by phone. I've talked to Dr. Pazak on the phone. I've talked to Dr. Cowder.
Yep.
I want to say Chowder. On the phone. I've just met him this evening. So, and I've heard of they call him Dr. A.
Dr. AC, that's right. Yeah.
I've not met him, but I've got several patients. Everybody that goes to that office is very happy with their care. So I don't know
Well, that's
what you
good.
all do over there, but you do something right.
Well, thank you for that compliment. We really do appreciate it. We try hard, and honestly, at the end of the day, we just try to take care of our patients.
Right.
That's it.
Right, yep. So I've known a lot of them through the years, and hate to see some of them go, but they
Yeah.
gotta retire.
That's
Gotta
that's
move
right.
on.
Exactly.
Gotta move on.
Yeah.
I don't ever want to retire, but that's because I'm
Well, you love the work that you do.
I do. I
Yeah.
love my patients. I love taking care of them, and
It's very rewarding.
it is.
It's very rewarding when
Yep.
you see them through their medical journey, right? Whatever ailment that you're treating, once you get to the conclusion of that and you finally actually treat them for it and they get better, that transition process
Yes.
is really great to see.
And I enjoy being with them through, let's say, a prostate cancer
Mm-hmm.
journey,
Yeah.
because I'll still see them intermittently for high blood pressure, high cholesterol, something, even though they're under your care for a
Right.
specific urological problem.
Absolutely. And I think that, what's great is the open line of communication between primary care and specialists, right? Specifically your office and our office. If there's, like, as you said before, if there's any question, you can always
Yes.
contact us.
Yes.
And we co-treat diseases as well, right?
That's right.
Which is great. So hopefully you guys have access to all of our information and our notes. That way you can go along with them as
Right.
we're treating their prostate
Right.
cancer and so on
Right,
and so forth.
yeah. So I don't want to have to send anybody over there for that, but unfortunately that happens.
It happens.
And we have to do that.
That's right. But early detection, right? That's key.
Absolutely.
Which we'll get into a little bit
That's
later.
exactly right. That's
Yes.
exactly right. Okay, so we've got, I just want to clarify right from the beginning
Yes.
the difference between a nephrologist and a urologist.
It's a great question. It seems to be a source of a lot of confusion.
Yes.
I answer this question on a daily basis
I
to
bet
my
you
patients.
do.
So there's a big difference.
Yes.
See, the nephrologist, they are the medical doctors of the kidney, right? When I say medical doctors, I mean they treat with purely medicine. They don't perform surgery. So dialysis, they handle that. Chronic kidney disease, they handle that. High blood pressure, that's not controlled with other medications.
Right.
They handle
That's
that.
right.
So all the medical diseases of the kidney. The urologist also deals with the kidneys, but we deal with the genitourinary tract, right? So that involves the kidneys, the ureters, which are the tubes that connect the
Yes.
kidneys to the bladder. The bladder, of course, the male genitalia, the prostate, the urethra, which is the tube you pee out of, and female genitalia as well,
Sure.
depending
sure.
on the issue.
Yeah. It used to be, long time ago, when there weren't a whole lot of specialists that would take care of, for instance, a bladder prolapse on a woman. Maybe you'd have a hysterectomy at the same time, or
Right.
you'd have to have the gynecologist working with the urologist
That's
to
right.
get it all taken care of. Now you've
Yeah.
got some gyno-uro combos
That's right.
that do that. So
That's a fellowship you can actually go into. So after urology residency is 5 years now. Some places are 6 years, but it's generally 5 years. And then after that, you can do a fellowship in urogynecology, which can range from 1 to 2 years.
right.
And those specialists, super specialists, I'll say, they specialize in the
Right.
bladder repair. I mean,
Right.
prolapse,
Right.
anterior posterior
Right.
prolapse, all
Right.
that.
So you don't do any of that for bladder prolapse?
So
things?
I personally don't. I didn't. That was not my area of interest, and so I don't necessarily do that surgery. But we get them to if women have that issue,
Right.
we get them to the right people.
Right.
Yeah.
Yeah. So it's nicer for the patient because it's just a one-stop shop versus had to see this one, had to see this one, had to, get the time ready
Yeah.
so the one doc could do it, and
That's right, yeah.
it just makes it a lot easier for the patient too.
Yeah, and urogynecology, we generally send them to Raleigh.
Yeah, I don't
Rex,
think
and-
there's one around here. I think Raleigh's the closest.
That's right, and
that
they-
I'm aware of anyway.
And they've been doing a great job there.
Oh, yeah,
So
yeah. They might have one in Greenville, I don't know.
I'm sure they do. Not that I haven't sent any there. Let's put it that way.
Yeah, I don't know that they might not.
With a large tertiary care center,
You
I
would think they
imagine
would.
But yeah, I mean, you're right.
Yeah.
They may not. Yeah.
So, well, let's see, I'm trying to think of one. All right, let's talk about, you do surgery. So what kind of surgeries do you do?
Yeah, so we, as urologists, we operate on all of the previously mentioned organs, the kidneys, the ureters, the bladder, any disease that is involved with that particular surgical disease that's involved with those organs, we treat. So a very common thing that we see are kidney stones.
Oh yeah, that's on
Right.
my list.
So
we're going to spend some time with
on
that. Go
that.
ahead.
Sure.
Yep,
But yeah,
yep.
so we treat kidney stones. You know, you start having some abdominal pain or some flank pain, and women have told me it's worse than childbirth.
I've heard
That's
that.
what women have told
Yes.
me, and so it's some unbearable pain. Generally, you go straight to the ER. They'll do a CAT scan. They'll find a stone. So it's a problem because the urine that's made in the kidney flows through the ureter and down into the bladder, right? Which then exits through your urethra. So when a stone gets stuck in that tube, the urine builds up behind that stone and causes swelling of that kidney, and that causes some extreme pain. Unrelenting pain sometimes. And it can be colicky too, right? Comes and goes, comes in waves. And so we treat that with surgery, whether it's shockwave surgery or we actually go up there and get it ourselves. But everything is minimally invasive. It doesn't require any incisions, generally speaking.
Right. So if you go and reach and get the stone, do you go through the back, through the ureter?
That's a great question. So
Puncture
they
into the
used
bladder?
to, yeah, before they had ureteroscopes and smaller telescopic instruments, endoscopic instruments, I'm sorry, they actually used to cut down, they made an incision, cut down to the ureter, opened it up, removed the stone, and closed it up. However, now, depending on the size of the stone, generally speaking, if it's a small stone, we go from the urethra, so we go from below. We go from below, enter the bladder through the penis or the female urethra, and then after that, in the bladder, this is a great example. In the bladder, there's two little holes. And so we enter through these holes to get into the ureter.
God put them there? The little holes?
God put them there. That's how the urine drains.
Oh,
exactly.
okay,
They're called the ureteral orifices.
Oh, okay. Yeah,
Yep.
I guess I did know that, now that you say that.
And so we go into that hole, and we go up into the tube where the stone is stuck, and we break up the stone, we remove it, and that's how it's done. However, it's a very large stone in the kidney. Then we go in from the back. We go in from the back, we go directly into the kidney, and we break it up, again, using endoscopic instruments. Our incisions aren't big, they're maybe this big. We go in, break up the stone, remove it, and then put a stent, which is a rubber hollow tube.
Right.
Coils inside the kidney, coils inside the bladder, keeps everything open for a
You make
brief
it
period.
sound so simple. It's just we do
It's
this and
simple.
this and this.
We do this
It's
every day.
simple. Okay, simple. All right, it's time for our first break. So you be thinking of some questions that you can ask our doc tonight. We'd love to know, or we'd love to know if you've seen him, or if you've had a kidney stone, or if you've had lithotripsy or some intervention like that. Give us a call, 407-1111. All right, we're going to hear from our sponsors, and then when we come back, we're going to have more talk about urology, so don't go away.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
There's a main nerve that leaves your back that goes into your hip and goes down your leg. It's called the sciatic nerve. A back injury can put pressure on that nerve, causing pain, numbness, tingling. Chiropractors can actually help that. At the Hammer Chiropractic Center on Sunset, we know exactly what to do. We have very good relationships with the doctors in Rocky Mount. We like to co-manage people's care. Some medications may help us do our jobs, and our jobs may help their medications work better.
Today, having the right healthcare plan tailored to your specific needs is vital to your peace of mind. The question is not if you will need the coverage, but when. And when that time comes, you want to be prepared. With the rising cost of medication, medical procedures, and doctor visits, you should know which is the right insurance plan for you. From life insurance, affordable health care, to Medicare, there are a lot of insurance options available, and choosing a plan can be overwhelming. Having Gus Tullis as your insurance professional on your side will give you peace of mind, because you will know you are covered with the insurance that meets your needs.
Hello, my name is Gus Tullis of Gus Tullis Insurance, and I've been helping people with their insurance needs for well over 20 years. Call me today. I'll answer any question you have. 252-937-6913. Looking forward to hearing from you.
All right, good evening, welcome. We're here, we're talking about all the questions you ever wanted to know about urology. And we've got a urology specialist right here with us tonight, so we're going to keep on talking about it. And we're going to, I'm just going to ask some simple questions that most of you probably already know the answers to. I don't know. But all of us have had, or most all of us have had a urinary tract infection at one point or another. So what exactly happens? How does that happen? Do men get it as often as women?
Not as often as women, but women definitely get it more often, but men are definitely can get urinary tract infections as well. So essentially, the most common organism in a urinary tract infection is called E. coli, and that's an enteric bacteria, which means that it comes from your feces. And so women have shorter urethras. Right. So the average urethral length of women is around 4 centimeters. And so because they have shorter 4 centimeters, that's it.
That's not very much.
No, but that's it. But because it's so short, right? Bacteria can travel easier into the bladder in women and proliferate and create an infection.
Right.
So what are the signs of a urinary tract infection? Well, you're going to have frequency, you have urgency, burning, stinging when you urinate, and also pressure, right? If that infection gets really bad, it can travel up to the kidneys, right?
Yes.
That would be called ascending infection. Once it gets to the kidneys, then you can have something called pyelonephritis, right, where your kidney gets infected. And that can be really bad, right? And so as far as urinary tract infections, women get them more often because they're anatomically more prone to it. However, men get them as well. Why do men get them? Well, it could be a variety of reasons, but a lot of them, foreign bodies, for example, men with chronic catheters can get urinary tract infections because anytime you have a foreign object in there, you'll have colonization. Bacteria will form a film, right? So those folks with chronic Foley catheters, they'll always have bacteria in their urine. That's just now they're colonized. However, if they're not having any symptoms, you don't necessarily treat it.
Right. And I know, do you think men that are not circumcised have more prone to, or that doesn't really have anything to do with
That's a good question. Generally, no.
Okay.
As long as the foreskin itself doesn't, incline you to more infections, it's more the hygienic aspects of it.
Okay.
Because when you urinate, you're supposed to retract your foreskin, urinate, and then reduce the foreskin. And if they're not necessarily doing that every single time, what happens is they can get some infection of the actual foreskin, right, balanitis, or they can get phimosis, which is your foreskin gets really tight and you can't pull it back all the way, and that can be painful. So there's many things we can do about that. Ultimately, with any of those things, if that continues to be a recurrent problem, we circumcise them.
Yeah.
And remove
And
the
you do
foreskin.
that too?
Yeah.
Do you do that in the office, or you do that In the hospital.
We do that in the hospital, yeah.
Okay.
I don't think the men would be very happy if I did
Well,
that
I
in the
wouldn't think so, but you know, I
Yeah.
mean, it doesn't seem like it's a real detailed thing, but I don't know.
No, you're right though. I mean, you know, in some countries they do it in the office because they have different tools. But currently, in the United States, we do it in the operating room.
Yeah.
We put them to sleep, they're
Right,
comfortable. It's a relatively quick procedure, 30
Uh-huh,
minutes. That's all it takes. You know, remove the foreskin. They'll have stitches all around the head of the penis, and these are all absorbable
Yeah.
in a month.
Is
they'll
it pretty painful for an older guy or an
come.
adult?
No, it's the same.
Not really.
It's really the same. Yeah.
About the same as even with the baby. I mean.
Yeah, so that's a great question. So with newborn circumcisions, you don't put the baby to sleep. We're talking like within the month of being born. That's done usually either at the hospital after they're born, right? And when that's done there, you just kind of you strap the baby down, give them some applesauce, and they're really happy with the applesauce. And then you just do a local anesthetic. You just put some lidocaine, some numbing medication. You do called a penile block, and then once that's done, just do it. They usually don't feel it too much. I mean, I have zero evidence, right? Because babies can't speak.
Right, that's right.
But that's the
right.
general
Yeah,
idea. Yeah.
Well, I mean, both of my boys were circumcised, and you know, there wasn't really any pain or there wasn't any incessant crying or things like that.
That's great.
Yeah.
Yeah.
So I guess doesn't hurt much.
I mean, yeah, and they use a tool for newborn circumcisions. There's a tool that they use. It's not the way that we do it for an adult. Right? Adult involves a few more steps, but yeah.
Okay.
General concept is the same.
Okay. And does circumcision, does that kind of, you know how things come in vogue and everybody does it, and then it's like there's like, well, I'm not gonna know, and then people tend not to do, or is that pretty much standard? Is it more of a cultural thing?
It's definitely cultural, but it's also just a choice. You know, every parent makes their own choice. There's pros and cons to each, right? Of course, but from a hygienic standpoint, easier to get circumcised because it's easier to keep up with hygiene with a circumcised penis as opposed to an uncircumcised. But there's no major repercussions of not doing a circumcision.
Okay, all right. So we've kind of talked about most of the problems and diseases. Are there any other diseases we can highlight before we move into the prostate? That's kind of what our focus is going to be.
Yeah.
What other kind of, now I know that like you'll do a kidney removal, like you have cancer of the kidney.
Yeah.
What about polycystic kidney disease? Is that urology or nephrology?
So as far as the medical treatment for that would be nephrology. They generally handle that. However, if it gets to a point where they're in renal failure, for removal of these, we would do that.
You would do that. Okay. Yeah, that's, I don't know why, that's a fascinating problem to me. I'm glad I don't have it, and I don't want anybody to have it, but it's just interesting.
It is interesting. Those polycystic kidneys, they're really big. They're huge, like this big.
Really?
They'll occupy the majority of your abdomen. Yeah, some of them can get extremely large, and they cause mass effect, and they push all the other organs out of its way. And yeah.
And can you just remove some of the cysts, or you don't do that?
No.
Like I know you don't. Like I've got cysts on my liver, and I asked Dr. Schellenberger, can you just remove some of them? They don't do that.
Generally, no.
Yeah.
So polycystic kidney disease, it's not like they have one or two cysts. Their entire kidney is just cyst.
Poly means many.
Poly means many, exactly. Their entire kidney is just cysts. They barely have any good meat. That's the best way to put it.
Okay.
They don't have any good meat on their kidneys.
And is that a hereditary thing?
Okay, yeah. There's some autosomal dominant polycystic kidney disease as well. Yeah, it can be.
It's a terrible disease.
It is, and these folks tend to go into renal failure a little bit earlier, right? And at that point, they are transplant candidates.
Right. Okay. Well, we talked about the kidney stones and you did talk about, stents and that kind of thing. do they still do a lot of lithotripsy?
We do, yeah.
Okay, so that's still pretty much used as much as any other kind of treatment for kidney stones?
It is, yeah. So there's different types of lithotripsy. So let's talk about the kidney stones. I brought it up because it's such a common thing that
Right.
people see. Let's talk about the causes
Yes,
of kidney
let's
stones.
talk about the
So that
causes.
we can prevent stones from
Right.
forming. The most common cause of kidney stone formation is dehydration.
Really?
That's the most common cause. Yeah, none of us are drinking enough water.
Oh, I know.
None of us, right? I see that you have water right there. That's excellent. But we should be drinking enough water to produce at least 2 to 2.5 liters of urine every day.
That's a lot of urine.
It's a lot of urine.
That's a lot of trips to the bathroom.
It is a lot of trips to the bathroom. But that's how much water we should be
Yeah.
drinking, right? So if that means if you want to produce that much, you should drink at least that much, especially if you have a very physical job and you're sweating on the
Yeah,
job,
in
and
the
especially
summer.
summertime. Exactly. We're doing gardening, right? We're outside, we're sweating, and we're still only drinking a bottle of water. That's certainly not enough. That's
No.
when we get those kidney
Yeah.
stones.
So, 2.5 liters.
Yep.
So, I tell my patients 64 ounces, and they balk at that.
Oh yeah, same. I
And-
tell them as well.
And,
Yeah.
but really, that's not 2.5 liters.
No, it's not. It's under, but that's okay. 64 ounces. I ask my patients to drink 64 ounces if they can, daily. But no one's going to make that change overnight, and I don't expect
I know.
anyone to make that
I
change
know.
overnight.
I know.
We say, generally what I say is, okay, let's say you're drinking 16 ounces daily. Currently, that's your baseline. I say, all right, great. Next week or tomorrow, I want you to drink your daily 16 ounces, but then drink a few extra sips.
Right.
That's 2 additional ounces, right? That's an
Yeah.
easy change
Right,
to make.
right.
So I say, do that for a week. Then drink 2 additional
Uh-huh.
ounces
I
the
do
next
same
week,
thing.
right?
Yeah.
So over time,
Right.
these small changes
Right.
become a huge change.
Right.
And then it's a sustainable change.
Yeah.
And that's what we're trying to go
Yeah.
for.
And I tell all my patients that they hate soda and they hate caffeine and they hate
That's right. I want you to hate it. I want you to hate it. Because I tell patients, like, oh, I drink soda. That's okay. I'm like, it's not okay.
No.
It's actually dehydrating you.
Yes.
Soda is not hydrating you at all.
Yes.
Listen, I love soda. Okay, if I could drink soda all day, of course I would. But I understand what it does to my body, and which
Right.
is why I refrain from
That's
drinking
right.
soda.
That's right. That's right. Tell my patients it's a treat. You can have it Sunday when you go out for lunch.
Yes, absolutely. Yeah, once a week, great.
Yeah.
But that cannot be your
But
main source of
people
fluid.
drink 6 and 8 a day.
Yeah.
First of all, I couldn't afford it.
No,
'Cause
it's also quite expensive. Yeah.
Yeah, I
exactly.
drink tap water most
Yeah.
of the I have well water. I live out in the country.
Oh, gotcha. Okay.
So this is actually tap water. I'm just using the bottle.
Oh, nice. Okay,
Yeah.
that's fair. I mean, water is water, right?
Right,
So
that's
as long
right.
as you're getting it. In addition to the water, you can also put some lime or lemon inside the
Yes.
water. That's a source of citrate.
Yes.
And citrate prevents stones from forming. And so that's
Oh,
something.
I didn't know
Yeah,
that.
the most common types of stones, right? Like calcium oxalate stones.
Uh-huh.
Citrate prevents those stones from forming.
Okay. So I know there's calcium oxalate.
Yeah.
I know there's uric acid ones.
Yeah, those are generally if your urine is very acidic, you can form uric acid stones.
Mm-hmm.
And the difference between calcium oxalate and uric acid stones are calcium oxalate stones, there's many differences, one of which is you can't dissolve calcium oxalate stones. They don't dissolve. You have to break them up and remove it, and or they
Using
have to
the
pass it.
lithotripsy or something.
Exactly.
Mhm.
But uric acid stones you can dissolve.
Really?
Yeah, if you give them potassium citrate and basically make their urine more basic, you can dissolve the stones.
Huh.
Yeah.
I didn't know that.
Yep. And then calcium oxalate stones, they are radio opaque, right? You can actually see the stones on an X-ray. Uric acid stones, you cannot see these stones on an X-ray.
Really?
Yeah. You can see them on a CAT scan, but not on an X-ray.
Huh. Yeah, I've got a patient that has uric acid stones, and she had multiple stones. She had multiple UTIs. She
Mhm.
finally went to UNC to a urologist there, and they removed everything but one stone. I don't know why they didn't remove the
One stone. Was it in the kidney, I guess?
Uh-huh.
Okay.
And I think it was bigger than the rest, or I don't remember the story.
I gotcha.
But,
Okay.
So I didn't know what to do. I don't know that she's ever had potassium citrate. I'm gonna have to ask her.
Yeah,
I'll call
I'm
her.
sure if they were uric acid and she saw UNC urology, I'm sure they prescribed potassium
Yeah.
citrate. Yeah.
That is really interesting.
Hmm?
So how much of that potassium, I mean, how,
The dosage, or
yeah, and how long? Dosage and how long?
I mean, generally you can do 10 milliequivalents twice daily.
Uh-huh.
For how long?
Forever?
Forever. It's to keep your urine basic to prevent the stones from forming. Yeah. But of course, you have to keep an eye on the potassium.
Of course.
Yeah.
Yeah. Well, so those are the two.
That's just, those are just two types. There's many other stones. There's cysteine stones. There's infection stones. That's magnesium, ammonium phosphate stones. I mean, yeah.
Are those common too?
Not as common. The infection stones aren't as common, and the infection stones are really soft, so you can kind of tell when you get up there and you use a laser to break up the stones. They just break up very, very quickly and easily, and you can't really grab them. Those are more infection stones. But let's talk about lithotripsy. So there's different types of lithotripsy.
Didn't know that either.
There's laser lithotripsy, and then there's shockwave lithotripsy. Shockwave lithotripsy essentially involves putting someone to sleep, but there's nothing that's inserted into their kidney or anything like that.
Okay.
It's just purely external shock waves that are going, and you target the stone. You always get the x-ray, you target the stone, and then once you target the stone, you can aim these shock waves at the stone, and as shock waves do, they're meant to break up the stones. And then after the stones are broken up and you can no longer see it on an x-ray, that would be considered successful. And then the patient, of course, would have to pass the stones on their own.
Yeah. So I think UNC Health do they have like a bus or some kind of a that comes, and is that the shockwave?
That's the shockwave truck. Yeah.
Okay, that's
yeah.
shockwave truck.
Yeah,
okay.
It's a truck. That's right. It comes in, it has the machine, and so we do all of our preoperative stuff in the hospital, and then we just roll them all into the truck.
Yeah.
Mhm.
Okay. That's what my husband had. He
Yeah.
just had a really bad outcome.
He had a rough time with that.
and
Yeah,
he
and
did.
that's one of the risks of doing shockwave. Of course, it hits that one stone, right? But it also hits the kidney surrounding that stone, and so you are, of course, at a higher risk of blood clots around the kidney. Yeah,
And that's what happened.
Yeah.
Now, do folks when they're older, do they have more of a propensity? Because he had never had one before.
You mean as far as a kidney stone formation?
Uh-huh.
It's not necessarily older or younger. It's really your hydration status.
Okay.
Most commonly, since that's the most common
That is
reason.
fascinating.
Yeah, it's hydration
Wow.
status.
I got a new bullet in my armor now. In my arsenal to tell my patients.
Please do. Yeah, I mean it's and the more knowledge is always the better, right? And so if you
Absolutely.
can treat them, and you can also educate them about kidney stones and how to prevent that. I mean, I think that will hopefully do greater good, but it's hard to change
I know.
habits,
I
right?
know. Yeah. Yeah.
And then so laser lithotripsy, what that involves is us actually going into the kidney or the ureter or wherever the stone is located, using a very tiny laser fiber, and actually using the laser to break up the stones, visually seeing it on our screens, breaking it up, and then removing it.
Now, is that done in the truck too, or that's done in the OR? Or?
That would be done in the operating room.
Okay.
Yep.
All
They're
right.
put to sleep, done in the operating room, all under sterile technique.
Okay.
Yep.
Awesome. Well, that's why I love this job, because I learn so much every
Yeah.
time. All right, we're going to take our next break, and next we're going to be talking about prostate cancer. So if Uncle George has prostate cancer and you want to know more about it, don't go away. Call Uncle George and tell him to watch it. We're going to talk about it because it's a big problem in this area, and we want to see what we can do to prevent it. Don't go away. We'll be right back after these few messages.
When faced with special care needs for elderly or disabled loved ones, families want compassionate, comforting care. That's Tender Touch Home Care Services' goal, providing the level of care we would expect for our own. With over 10 years of home care excellence, Tender Touch provides an array of services that keeps your loved one at home. From personal care, light housekeeping, errands, and meal preparation, to our private duty care program, which combines all of our home care offerings in one package.
Tender Touch Home Care Services, where your needs are our concern.
There's a main nerve that leaves your back that goes into your hip and goes down your leg. It's called the sciatic nerve. A back injury can put pressure on that nerve, causing pain, numbness, tingling. Chiropractors can actually help that. At the Hammer Chiropractic Center on Sunset, we know exactly what to do. We have very good relationships with the doctors in Rocky Mount. We like to co-manage people's care. Some medications may help us do our jobs, and our jobs may help their medications work better.
Today, having the right healthcare plan tailored to your specific needs is vital to your peace of mind. The question is not if you will need the coverage, but when. And when that time comes, you want to be prepared. With the rising cost of medication, medical procedures, and doctor visits, you should know which is the right insurance plan for you. From life insurance, affordable health care, to Medicare, there are a lot of insurance options available, and choosing a plan can be overwhelming. Having Gus Tullis as your insurance professional on your side will give you peace of mind, because you will know you are covered with the insurance that meets your needs.
Hello, my name is Gus Tullis of Gus Tullis Insurance, and I've been helping people with their insurance needs for well over 20 years. Call me today. I'll answer any question you have. 252-937-6913. Looking forward to hearing from you.
All right, we're back. Welcome to Here's to Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center, and I'm here tonight with our urological specialist. I'm so excited to have him. He's really a nice guy. I've had a lot of good conversations in between while you're watching the commercials. Anyway, we're going to focus now on prostate health and prostate cancer. So I'm just going to pass it to you. I'm not even going to ask a question.
Sure.
What,
So,
well,
go ahead. Why don't you ask a question? Go
okay.
ahead. Yeah.
What do men do to have the healthiest prostate they can have?
Sure.
What do they do?
So, there's really nothing to do. The prostate is the prostate, and it's going to, whatever happens is going to happen, right? So, what do I mean by that? First, let's talk about the benign diseases of the prostate. As men get older, so I'm going to have this diagram here.
I hope you can see
Can I
it.
just use your pen for a moment?
Sure, of course.
Thank you. Okay.
Hey,
so,
Lee, can you focus in on what the doc's holding here?
let's just put this out of the way here.
There you go.
All right, perfect.
Thank you.
Yep, that's great. Thank you. Awesome. So this is the bladder here, and that bladder is connected to the prostate. So generally speaking, urine flows from the bladder through the prostate and then out through the penis. As men age, the prostate tends to increase in size on average of 2.5% every year. So if the prostate,
Oh, okay.
that's on average. Some grow faster than others, right?
Right.
So as the prostate increases in size, the channel that the urine flows through becomes more narrow.
Right.
And that can cause bothersome symptoms such as frequency, urgency, weak stream, getting up multiple times per night to urinate. And so what ultimately is a consequence of that is the bladder here has to push harder and harder to push that urine past that enlarged prostate. And what happens to that bladder if this enlarged prostate is not treated is the bladder is a muscle, just like any other muscle in your body. If it works hard, it becomes really thick. And when the bladder becomes thick, it can get permanently damaged.
Oh.
And so if I turn this around, This is actually what a healthy bladder looks like. But over time, if we do nothing about an enlarged prostate on a patient that is symptomatic, then you start to see these bands on there. And these bands become even thicker and thicker, ultimately to a point where it's permanently damaged.
Huh.
And so when you start seeing these webs, when you do a cystoscopy, which is basically taking a camera to look inside the bladder, this is a permanently damaged bladder. At that point, there's not much we can do about it. It is what it is. So we always want to prevent the progression of this to this. Right? And so that's why we always aim or advocate for earlier intervention on the prostate in order to prevent this from ever happening. And so there's a couple of things that can do that, right? And so if I were to take a look inside an elder man's prostate, it would likely look something like this, where you have this tissue here obstructing our view, right? I have to get past all of that tissue to get into that bladder here. And so there's things we can do to help the prostate go from this to this. And you see the difference, right? This is wide open. That little hole in the middle is actually the bladder. So that's the entryway into the bladder. That's called the bladder neck. Yeah. So if I can look into the bladder this is a view from the bottom of the prostate.
Gotcha.
If I can look into the bladder from the bottom of the prostate, which is, if my camera's here and I can look directly into the bladder, you can only imagine that the urine's going to flow a lot easier through that open channel, right? As opposed to this, the urine's going to have a little bit more difficult time flowing through this, right? And so a couple things that can help with that. So first is medication, right? So Flomax, that's a very popular medication, right? The generic is tamsulosin. And so what that does is it relaxes the smooth muscle layer in the prostate as well as the opening of the bladder. And when it relaxes, it helps the patient pee a lot easier. However, it does nothing for the actual size of the prostate. Right. It does nothing for the actual obstructive portion, right? So essentially, men do quite well with that medication initially, but sometimes over time, that medication is no longer as effective. And while it's easier for them to have to urinate with that medication, unclear what's actually happening to the bladder. Are we actually saving the bladder from going from here to here, right? So is that having any effect on the actual contractility of the bladder? And so what we advocate for is earlier surgical intervention, and there's a lot of minimally invasive surgical things that we can do. And so the most common thing that everyone always hears about and they hear their fathers talk about is they call it the roto-rooter job, right? So that's called the TURP. Right. TURP stands for the transurethral resection of the prostate. So essentially what that is we, of course, evaluate their prostate in the office to see that they are indeed enlarged. The indication for that is, of course, they're having bothersome symptoms. And Flomax, nothing is helping. They're still getting up 5 times a night. So we look in the office, their prostate is enlarged, we see something like this. So transurethral resection of the prostate is essentially we go into this space, which is the prostate, and we take a hot loop. It looks like a U. And what we do is we just shave the prostate. So we start shaving the tissue down. And so we remove the inside portion here, right, a portion of it, and create this opening by removing tissue. And so they have a much wider channel, and they should be able to urinate a lot easier through that channel. It's generally a same-day procedure. So afterwards, they will have a catheter in place. A catheter is basically a tube that goes from the penis directly into the bladder, and it drains all of the urine continuously into a bag. And that catheter, of course, is temporary. And so that catheter, as long as the urine looks clear in the recovery unit, they generally go home the same day, for me at least. And we remove the catheter 3 days later. And once we do a procedure like that, we have them stop all their medications for their prostate because they don't need it anymore.
Everything works again. It's back to where they started.
Exactly. So that's an option, right? That was what was the gold standard, I should say. But there's other options these days, right? And so one of which is a minimally invasive option, which is actually helps a lot of men. It's called the UroLift, which is actually what this is from. So what the UroLift is, after evaluating their prostate, taking a look inside, seeing what their anatomy is like, also we measure the size of the prostate. And we do that with an ultrasound. Very similar to a rectal exam, if anyone's ever been to the urologist or primary care office, where they check their prostate through the rectum. Instead of our finger, I use an ultrasound probe, which is about this big compared to the size of my finger, and that only goes in for about 30 seconds approximately, just to measure the size of the prostate. So based on the size of the prostate and what it looks like on the inside, I generally give patients, what I do is 3 options, right? First is 4 options actually. First is the option that they're already doing. Just continue your medication. We don't need to do anything else. If you're happy with the way things are, we'll just leave it at that. Of course, if I'm getting to the point where I'm having to look inside their prostate, the medications aren't helping, right? But we shouldn't wait until medications aren't helping, but that's a different issue. One is called the UroLift. So what this is we go into their prostate and we put implants. And what the implant does is it pushes the tissue to the side. And so over here, as you can see, the tissue is all kind of congregated in the middle here. Once I go and I put the implant there, it actually pushes that tissue to the side.
Okay.
And it pushes that tissue to the side and creates this nice opening here. This procedure only takes about 10 to 12 minutes. That's it.
Oh, wow.
Minimal side
effects.
effects.
Does it last like forever? Or
yeah, the five-year data, because it's started in, it's relatively new within the last 10 years, but the 5-year data shows that 87% of patients don't require anything else after.
Oh, wow.
At 5 years.
Well, that's the way to go.
Yeah, at 5 years.
Yeah.
And so this is great. We recently brought this to UNC Health, and specifically at Nash. And we've been doing quite a lot of these, and we're actually on our way, hopefully at the end of this year, we are going to become a center of excellence.
Really?
Yeah,
that
yeah.
is awesome, because I know how much trouble and how hard that is to obtain that.
Yeah, so once we become
it's not easy.
Yeah, it's, it takes time, right? This is an
Sure.
art. And so once we get the openings and the outcomes where patients are doing really well, most of my patients do, then once we get that designation, I think we'll be at a, at a position to treat a lot more patients and to help a lot more men, most importantly.
That is awesome.
Yeah. And so that's one option, right? That's literally, of course, generally the UroLift is rated up to, they say 100 grams. That's the weight of the prostate, right? That's the size. Anything beyond that, UroLift won't be the best option because it just won't be the, let's put it this way, it's not the optimal option. The length of the implant is only about 3.3 centimeters.
Okay,
and so if their prostate's wider than that, it's not going to do much. So for those prostates that are over 100 grams, I do something called a laser enucleation. So imagine an orange, right? You have the rind on the outside and you have the fruit on the inside. Imagine putting your finger in the space between the fruit and the rind and then rotating your finger 360 degrees. You separate the fruit from the rind. Then you could push the fruit out, but the rind stays intact. That's what the prostate's like.
Okay.
So essentially what we do is, this is kind of a 2D cross section, but we go in here with the laser fiber and we make a little incision on the inside. Everything is done through a endoscope. We don't make any cuts on the skin. And we basically core out that entire inside and I push it into the bladder.
Wow.
And then I use a different tool to remove that tissue. But at the end of that procedure, they'll have a huge space where this enlarged prostate was, right? And they have a catheter at the end of that procedure as well. With that particular procedure, I admit them overnight in the hospital with some fluid running through the catheter to just wash out their bladder. But as long as the urine looks pretty clear the next day, I send them home. And then I remove the catheter 3 days later. And they do really well. They have a much better flow. They say, wow, this is almost like when I was a teenager.
Oh, wow.
Yeah.
That's good.
Yeah, because you remove that obstruction.
We want everything to work like it did when we were a teenager.
Exactly. But the recovery time for the resection of the prostate and the enucleation that I just talked about is going to be a little bit greater in time, right? That's generally about a week or two.
Oh, that's
However,
not bad.
with the UroLift, the recovery time, again, UroLift for the right patient, right? Everything for the correct patient.
Correct.
The UroLift, the recovery time is 24 hours.
Oh my gosh.
Because the catheter, they go home the same day. The catheter comes out the next day. They remove it themselves. The nurses teach them how to do it. And after the catheter's out, they're ready to go. You know, they'll slowly start to see their stream improve. However, the frequency and urgency, it takes a little bit longer to improve, only because I may fix their prostate in one day, but I don't fix their bladder in one day. You can liken it to a knee operation, right? Someone injures their knee and they get their knee operated on. They are not running a marathon the next day.
Correct.
They have to rehab that
That's
knee.
right.
Right? So just like that, once I fix the prostate, the bladder has to rehab itself. However, the beauty of that is you don't have to do anything. The bladder will reprogram itself.
Yeah, it does its own
right?
thing.
You just have to give it a little
the
bit of
body
time.
will repair itself. You just got to
Exactly.
let it do it.
You just got to give it some time. Yeah.
So where's the closest to get UroLift other than here? Like Wilson?
I don't know if I think the urologist in Wilson is doing the UroLift, and we can zoom back out. The urologist in Wilson, I believe, is doing it, but you could also do it in Greenville, I think, and in Raleigh.
Okay.
They're doing it in Raleigh.
We want to keep everything right here because
course.
we take
Yes.
good care. But I had a buddy of mine that just had a TERP, and I'm wondering why he did that instead of, I don't know.
And it could be various reasons, right? It could be his prostate anatomy was better for a TERP
Or
as
maybe
opposed
it
to a
was too
UroLift,
big
or
for the
yeah,
UroLift.
exactly,
Yeah,
exactly.
yeah. Well, we didn't get to prostate cancer.
Oh no, I feel like there's just never enough time.
I know.
There's
Well, you
never
know
enough
what?
time.
You're going to have to come back.
I'd be happy to come back.
That would be awesome. And we'll bring your wife with.
Sure, yeah.
That would be, because she's a doctor. She's a family doctor, so that would be a fun
Yeah.
show. But anyway, just, we were talking, and one thing about prostate cancer, it's higher in the African American population, unfortunately.
unfortunately, yes.
We don't know why exactly. And there's a high incidence here in Rocky Mount. So I urge all of you men to talk to your primary care provider and say, look, you know, I have this problem, I have that problem. Don't hold these symptoms. Don't think they're natural. Just talk to somebody about and find out if there's something else that can be done, which probably 95% of the time there is something else that can be
There's
done.
always something that can be done.
Yep.
Generally speaking.
Yep.
Yes. If you catch it early enough.
And drink your water.
Please drink your water.
2.5 liters a day. I'm nowhere near 2.5 liters a day, I can tell you that.
It's a process.
Yep,
It's
that's
a
right. I'm going to
process.
start adding my couple ounces every sip. So thank you so much.
Of course.
It's so nice to meet you.
Yeah, nice to meet you,
Great
and thank you
have
so much
here.
for having me. We
Yes,
really appreciate
sir.
it.
Yes, sir. And we will be back next week with more Here's to Your Good Health. Good night.
Good night.